Hi, today we are going to discuss point of care ultrasound assessment of the abdominal aorta. So thank you for joining me. Okay, so the objectives for today, we're going to want the learner to be able to describe how the aortic assessment can be done quickly and at the patient's bedside. Also look to identify how POCUS can expedite the diagnosis of high mortality pathologies such as AAA and aortic dissection. We're also going to examine how protocols utilized to increase sensitivity and specificity of exams and identify patient factors that support the utilization of POCUS as a screening tool for the abdominal aorta. And finally, we're going to be able to describe why accurate diagnosis of the aorta is dependent on other factors such as utilization of standard protocols, knowledge of anatomy, visualization of anatomy without obscuring bowel gas, accurate measurement techniques, appropriate instrument settings, and the utilization of color, B mode, and even spectral to assess the size and function of the aortic anatomy. So some considerations about the aorta. Abdominal aorta pathologies can lead to some very significant risks to the patient. So by identifying these early and accurately, it can lead to life-saving interventions. Abdominal aortic aneurysms, or AAAs, are the most common pathology of the aorta. Now, a AAA, once found, is not necessarily standing on its own. Oftentimes, it is correlated with an internal thrombus within the aneurysm, an area of dissection within the aneurysm, and then it has a moderate probability of rupture depending on the size. 30% of ruptures are misdiagnosed initially because of the patient's kind of vague symptoms. And so being able to identify this AAA or ruptured AAA early can help you get that patient to surgery and increase the probability of survival. All of these AAA findings can have a very high mortality rate of about 90% without immediate interventions. And so it's going to be very important that you can get this done quickly and accurately. Another important consideration is to understand the increased incidence of AAA is found with certain factors such as advancing age, history of smoking, genetic predispositions, peripheral artery disease, and then it's going to be more common in males. So abdominal aortic aneurysms are found in about 4.7% of men and 3% of women. The incidence in men is going to peak at about 80 years of age, where it's at 5.9%, and a little bit later in women at 90 years of age, where it's about 4.5%. About 9,000 Americans die of a AAA rupture or other complications per year in the United States. This is the 15th leading cause of death in the United States between ages of 60 and 64. And the utilization of POCUS could really have an impact on these mortality rates. So POCUS has a 97.5% sensitivity and 94% specificity for identification of a AAA. In order to accomplish this, POCUS aortic AP measurements must be taken, and they find that these measurements typically correlate to those measurements found on CT within 2 millimeters, and of course come without the necessity of transporting that patient into the CT suite and without giving an already unstable patient contrast and some of those other challenging decisions. So indications for an aortic exam often starts with abdominal discomfort, especially with those with increased risk factors. So if you have an elderly gentleman, he's smoked for years, his father died of a AAA rupture, and now he's complaining of some back pain or abdominal discomfort, this might be a really good indication for an exam. Hypertension, this is going to be a really good indication that there's a possibility of aortic rupture, and so that would be something you'd want to look at immediately. Back pain, as I mentioned, kind of goes with that abdominal discomfort, and then a pulsatile abdominal mass. And as a general sonography, we'd often see these pulsatile abdominal masses, sometimes in just very thin patients where you could palpate their their aorta easily. But if it's in a patient that has a much higher risk factor, then this is something that should be taken very seriously. The Ultrasound Preventative Task Force made some recommendations that to screen all men between ages of 65 and 75 with a history of smoking. I apologize for my typo here. So in order to accurately look and evaluate the aorta, we need to do a little bit of review of its anatomy. So along with the IVC, the aorta is a retroperitoneal organ. So it is going to run posterior to the peritoneum back there in the posterior abdomen, along with the pancreas, the kidneys, the IVC, and so on. It extends from the abdominal aorta, I should be specific here, extends from the diaphragm to its bifurcation at the common iliac arteries, which you can see here. This bifurcation is usually going to appear at about L4. So right in this region, that should be about L4. So the typical size in AP diameter, so if we looked at the aorta and we're going to measure it from front to back, it should be about 2 centimeters. Once it gets greater than 3 centimeters, it's technically considered abnormal. Now, sometimes you'll see those ectatic aortas where they'll just have a generalizing relaxation of the aortic wall, and so we also have some other criteria that we can use, but we typically use just getting any area greater than 3 centimeters is going to be concerning. The branches in review, the branches of the aorta, the first branch is going to be the celiac axis. That comes off the anterior aspect of the aorta, and then it is going to bifurcate into the hepatic artery, the left gastric artery, and the splenic artery. Just a short centimeter or so down, then we're going to have the superior mesenteric artery that's coming off to feed basically the intestines. That is going to come off anteriorly and descend just anterior to the aorta. Next, we'll have the bifurcation of the left and right renal arteries. Below that, we have the inferior mesenteric artery, which on most patients is going to be very difficult to identify on ultrasound. Now, lower and laterally will come off the gonadal arteries and the lumbar arteries. Again, those are rather small. They'll be in this general region, so you might not detect them on ultrasound, but if they're dilated for some reason, you have an aneurysm in one of those, you may actually see them. And then here we have our bifurcation of our left and right common iliac arteries. So we go celiac, superior mesenteric artery or SMA, left and right renal, inferior mesenteric artery or IMA, lumbar, gonadal, and then our iliac bifurcation. So when we go ahead and start the scan, these scans are done transabdominally, usually at the patient's midline. Because it's going to be at somewhat of a depth, we are going to use the 3 to 5 megahertz curvilinear transducer in order to be able to penetrate deep enough. Now, if you have a very, very thin patient, a pediatric patient, something like that, you might get away with using a linear 6 to 12 megahertz, and that's wonderful. You'll get beautiful images, but on your everyday patient, you can expect to use a 3 to 5 megahertz curvilinear. Obviously, the thicker, the more gassy, the more obese a patient is going to adjust, going to change your ability to see well in that aortic area with no artifact. So you are going to be somewhat limited by the patient's habitus in this exam. So for the scan, you're going to evaluate the aorta in long and transverse from the hiatus of the diaphragm all the way through the bifurcation into the common iliac arteries. So to begin the actual protocol, you're going to start out in transverse. So you're going to want to find the notch on your transducer, and you're going to want to make sure that that notch is pointing toward the left of the patient, so that you know that you're in transverse in correct orientation. Then you're going to want to identify the subxiphoid space just below the sternum and apply quite a bit of pressure here. Lots of pressure is typically necessary to kind of compress gas out of the way. So if you feel like you're pushing relatively hard, push a little bit harder, and hopefully that's where you're going to get your best image. So keep your transverse orientation with your transducer, and then you're going to want to start to move inferiorly in that plane, following the aorta. And in this transverse plane, it's going to look as a mostly circular area. At areas of bifurcations, it can be a little bit more oblong, as you can see here, but in general, it's going to have more of this circular appearance that we see right here. So once you've identified the aorta, you have good compression, then you're going to want to start advancing inferiorly throughout the aorta, all the way from that, again, the hiatus of the diaphragm all the way down to those common iliac arteries. And you're going to want to kind of pause along the way as you see each of these landmarks so you can know what level you're at. So here, this is the first landmark you're going to come to. Here's the aorta, and here's what we call the seagull sign. The seagull sign represents the celiac axis. So here's our celiac axis coming off of the aorta, bifurcating into the hepatic artery as well as the splenic artery. Now we know there's also a left gastric artery here, but because it's typically much smaller, we're really focused on the splenic and the hepatic arteries here. As you move down a little bit more inferiorly, you are going to identify the superior mesenteric artery. Here you can see the superior mesenteric artery again. Here's the aorta. And as you continue moving down, after the superior mesenteric artery branches off, you can still see it in transverse, and yet you're going to come across the aorta bifurcating with these, sending out the left and right renal arteries. It's not uncommon for these to come off at slightly different angles, so that is pretty typical for what you would expect. Now you're going to continue down, moving down inferiorly, watching the circular structure of that aorta, making sure that you're not seeing any areas of major dilatation or changes. And then eventually about the umbilicus region, you're going to see the bifurcation into the iliacs, which should look just like this. So if you're having difficulties getting this region and you're right near the patient's umbilicus, we usually get really poor or really bad ultrasound dropout through the umbilicus. So a couple different approaches is to stay above the umbilicus, press with additional pressure, and then without sliding into the umbilicus, simply angle your transducer inferiorly. If that's not effective to show that bifurcation, then you can always take your probe, jump it down below the umbilicus, and then angle upward, trying to get that distal aorta. If you see an area of focal dilatation anywhere along as you progress down the transverse aorta, you're going to want to make sure that you're going to measure that area and evaluate it for its diameter being greater than 3. Once you've completed your transverse assessment, then you're going to return right up to where you started at the subxiphoid area, rotate your transducer 90 degrees. Now the notch in your transducer should be pointed toward the patient's head. Now you're going to have to evaluate the aorta in long, looking for size, measuring it, and assessing it for any dilatation. Now, long can be a little bit more challenging to keep your aorta within your image, especially if you tend to have a wandering hand like many of us do when we're first starting scanning. The IVC is going to lay just to the left of the aorta. So if you're ever wondering if your hand has wandered off the aorta into the IVC, utilizing color can quickly show either pulsatility within the aorta, phasicity within the IVC that would help you get back on track. And if in doubt, you can always just turn to transverse, re-identify the aorta, and then rotate 90 degrees back to long. Now, when you're looking at the aorta, you're going to scan it from, again, the hiatus up here all the way down to the bifurcation. And as you're doing this, you're going to want to be trying to stay in the center of the lumen. You're also going to want to take just generalized measurements at the proximal region, the middle region, which would be about here, and then the distal region as well. Now, as you're making your way down this aorta, you're going to see those same branches we saw in transverse, where here you see the celiac axis, here you see the superior mesenteric artery. Underneath the superior mesenteric artery, we see the left renal vein. Now, because the renals are going to come off lateral and we're scanning down the middle of the aorta, you won't identify those in true sagittal of the aorta. So finally, you're going to come all the way inferiorly, and again, as you're getting towards that umbilicus, you're going to see the aorta begin to taper, and that will be the distal aorta. Okay. And you can recognize this image is kind of a nice one, demonstrates the vertebral bodies and how close that aorta is in relationship to those vertebral arteries. Now, if you're in true midline of your patient, you will not, like I mentioned about the renal arteries, you will not see them because they're coming off the lateral aspect, and that's not in the view. Same goes for our iliac arteries at the bifurcation. So if I were to be in perfect mid-sagittal plane coming down, I would just mostly see the aorta come to basically a blunt end. If I wanted to evaluate those iliac arteries in long, you would have to move the transducer off of your patient's midline and then angle back towards it. And if you do that, you can pick up something that looks like this, where it's kind of more of a coronal view, and you can see those iliac arteries after the bifurcation. So as I mentioned, you're going to want to measure that aorta in proximal, mid, and distal and assess making sure that it's 2 or at least under 3 centimeters. If you see it enlarged all the way down, that would be considered more of an ectatic aorta, whereas if you see a focal enlargement, that would be then your aneurysms. So now, not all patients are going to scan well. Some patients, this will be the easiest exam in the world if they're nice and thin, if they don't have a lot of gas. But a lot of patients, especially those with seems like older men, tend to keep a lot of gas in their transverse colon, making that proximal aorta and sometimes the rest of it very difficult to visualize. So when you come across a patient like that, you can be aware of some different windows or areas you can look to still try and get the same image. So one of the approaches that you can take is the coronal approach, where you're actually going to come way off to the side of the midline and you're going to angle back kind of as this operator is doing here and get that coronal view. So one of the benefits of looking this way is that when you're in coronal rather than in AP or anterior to posterior, you actually can see the renal arteries come off better, and you can see the iliac arteries come off more effectively. So, and you can see this person, this operator is just a little bit off midline, angling back. This operator is coming way off midline and angling across, and if you can see the indentation of that patient's abdomen, they're providing a lot of pressure to get this image. So don't be afraid that you're going to have to push for this. So if you're not getting it in the midline, don't fear. There's still other options to still try and get a really good image. If your patient is able to, you can also have them roll into a left lateral decubitus and get that coronal scan that way without wedging your wrist quite so bad. So when we're measuring the aorta, like I mentioned, we're going to measure it in AP, so anterior to posterior at proximal, mid, and distal. And then we're also going to measure it in transverse. This operator here did a little bit of an overkill. They actually measured it AP in transverse and width in transverse, and then AP in longitudinal or long. So it's a little bit of overkill. Really, we typically, traditionally, just do an AP measurement in long, like this, and then we would do our transverse measurement across the width of the vessel like this. When you're setting your calipers, you want to make sure that you are setting your caliper just to the outside of both walls of the aorta, and that's how you're going to get your accurate measurements. So we go outer wall to outer wall. And then all measurements should be less than 3. The other thing we like to teach is that you never want to measure just straight down from your screen, because as you see the aorta is kind of progressing up at an angle, we want to be 90 degrees to the aortic wall. Like I would measure like this rather than like this, because that's going to elongate the measurement. So make sure, kind of imagine that line of the lumen in measuring perpendicular to the line of the lumen to get your most accurate measurement. So when you're looking at your aorta, what are you worried about seeing? And the first thing you're most often going to see is going to be an aortic aneurysm. So the aortic aneurysm is defined as a discrete area of aorta measuring greater than 3 centimeters in diameter, or with a greater than 50% increased diameter compared to other regions of the aorta. This is where that ectatic or aorta comes into play. So if you have a patient with just a very ectatic, dilated aorta all the way down, we can't necessarily call that the whole thing an aneurysm. But if within, say that ectatic aorta measures about 3 centimeters all the way down, but at one point it measures 6 centimeters. If you have a 50% increase beyond the 3 centimeters it was the rest of the diameter, then that would be significant enough to call that particular area an aneurysm. Now, for your normal patient that has a pretty normal-sized aorta, anything over 3, you would just go to identify that as an aneurysm. Of course, the larger the size of the aneurysm, the more likely they are to rupture. We have a few different types of aneurysms. The first is a fusiform aneurysm. This is one where you have it concentrically dilated all the way around the vessel. So if this is my aorta coming down and all of a sudden I see this bulbous outpouching, that would be a fusiform aneurysm. A saccular aneurysm is going to be more one-sided. It's hanging off the side, one side of the aorta. And then we have what we call a pseudoaneurysm, and this is often caused by a hematoma post an iatrogenic effect. So maybe they were having surgery, or maybe they had trauma and there was a small rupture in the vessel wall. That rupture was allowed, bled out a little bit, and then the body quickly encapsulated that as a hematoma. In that particular case, if there wasn't still communication here, this would not be an aneurysm. This would be what we call a pseudoaneurysm. So you just want to be aware of those so you don't confuse those with a true aneurysm. The standard treatments, according to the Sony text, are going to vary according to the size of the aneurysm. So typically at this point, most aneurysms that are measuring 4 to 4.9 centimeters, they'll just monitor once a year. 5 to 5.4 centimeters, they'll monitor about every 6 months. And then 5.5 centimeters and above, they are going to suggest surgical repair if the patient is surgically a good surgical candidate. If not, they may just continue to monitor it if they didn't feel the patient would survive surgery. If a AAA is identified and you're sending them on to a surgeon or somebody else, make sure that you're trying to identify whether that AAA is either supra or infrarenal, as it will help the surgeon determine the surgical approach. So you can just kind of trace it back, see if you can identify those renal arteries coming off, and then describe whether it is above or below those renal arteries. So let's say you did go ahead and find your AAA. You took all the proximal, mid, and distal measurements. You took transverse measurements, but you identified this one fusiform-looking AAA like we see here in this example. When you find a AAA, you're going to want to measure it in multiple places. The first place is you're going to measure it proximal to the aneurysm. So if this is my aneurysm in long, this is not the best example, but I would measure the aorta in AP proximal to the aneurysm, distal to the aneurysm, at the largest width of the aneurysm, and I would measure the aneurysmal length and then identify if it was infra or suprarenal. Then you can go into transverse, and again, you're going to measure in transverse proximal to, at the widest, distal to the aneurysm. The other thing that you want to do is you want to adjust your B mode gain. So good, and I know I've talked about this repeatedly in previous lectures, so hopefully I'm not boring you too much, but good practice for your B mode is to take your brightness gain and turn that gain way up as high as you can until it's almost a whiteout, and then taper back off of it until you feel like you've removed all of your artifact and left all your real information. As you can see in this particular patient, they have a large thrombus. What might be a temptation oftentimes is to think of that, oh, that must be an artifact, and continue to turn your gain down until it's entirely blacked out. And that would be an error because we would basically hide a thrombus that existed. So make sure you're practicing that good sensitive B mode protocol in order to show a thrombus when one is present. Then you can add your color. The color is going to help determine the extent of the lumen. It's also going to demonstrate if there's any leakages of the area and how much turbulence is occurring within that area. So that's going to be really good information to provide. Now, a AAA is associated with an aortic dissection, but they are not always, they don't always go hand in hand. So aortic dissections are extremely dangerous. There's a couple different types. Type A originates from the ascending aorta, meaning right where the aorta comes off of the heart. This is going to be the more common. B originates from the descending organ. So it's usually a type B that we would end up seeing in the abdomen. Of course, we're not going to be the best at looking for intrathoracic area dissections because of the lung field. They could be found with an echo, but with just your general scanning, you're typically not going to see these. So a CT or a transesophageal echo would be much more efficient at finding those intrathoracic dissections. So we know that once a dissection begins, it can spread. So the dissection is where the tunica intima is going to separate from the tunica media, and it's going to create what's a false lumen. As that false lumen gets larger and larger, it is going to cause obstruction of the true lumen, which will then mean that you cannot progress that arterial oxygenated blood to the organs as necessary. So it's usually going to be a type B that we're identifying in the abdomen. So the role of POCUS with aortic dissection in the abdomen is to, number one, to identify it. Number two, we need to identify where the flap is, which part of beyond that flap is the true lumen, which part is the false lumen. Color Doppler will be very effective in helping us do this. Whatever the problem is, this patient with an aortic dissection would need immediate surgical intervention. So just a few notes about identifying these aortic dissections. As you can see, the tunica intima is a very thin echogenic line here. This could very, very easily be overlooked. So again, I can't stress the importance of practicing that sensitive B mode operation of your equipment where you're turning that gain all the way up, tapering it off, making sure that your eyes are looking at this and understanding that this is not just an artifact that you're trying to get rid of, but that it is a true pathology. Once you've seen that, you can prove it to yourself by adding color. Here's where you identify the true and the false lumen. You can also look for the extent of how far down it's going. And then in transverse, when there is a dissection, you will see the true and false lumen separately. So those are all going to be essential components in making this very, very important diagnosis. Now, this patient that we're looking at here, this is sort of the ideal patient. You can see that the images are very clear. We can pick up this dissection, be aware and be very humble because it's going to be those thicker patients where we're having artifact throughout the whole aorta that, are actually usually at higher risk of these. So make sure that you're always practicing your best protocols, always trying to use best scanning practices, and that will help you pick up these much more efficiently. So in summary, this was a speedy lecture today, but hopefully you get the basics, just a quick review of your anatomy. Scanning the aorta itself is typically pretty easy. It's just going to take a lot of arm strength and practice basically turning from long to transverse on that aorta. And then really it's all about manipulating your scanning technique, your color gains and your B mode gains and all of that. With all of that, an aortic assessment can be done very quickly at the patient's bedside. It expedites diagnosis of high mortality pathologies such as AAA and aortic dissection. It also is going to help get them to surgery faster and increase the probability of survival. Practicing well-implemented protocols must be utilized to increase the sensitivity and specificity. With exams, remember, with good protocols, they're at about 97%. If you're not following protocols, they may be very, very low. So the exam is only as good as the operator, so make sure that you're utilizing all the best practices. Some documentation supports utilizing POCUS as a screening technique for the abdominal aorta, especially in patients that have multitude of risk factors that we talked about. And then finally, some of those things that are really going to help us optimize our scanning would be utilization of the standard protocols, making sure you're assessing it, the entire aorta and transverse and the entire aorta and long, and taking your measurements accurately, utilizing those sensitive gain techniques. Having a good knowledge of your anatomy, making sure that you're not accidentally ending up in the IVC. Making sure that you're identifying which of the branches you are near, at, or above. All those things are going to be really helpful. Also, the ability to visualize without obscuring bowel gas. So being aware that lots of our patients are going to hold a lot of midline bowel gas, taking the steps to utilize different windows, such as the coronal window, that can really be helpful in getting past this challenge. Maintaining those accurate measurements where you're measuring outer wall to outer wall perpendicular to the vessel, not perpendicular to your screen, that is going to be essential. And then getting the appropriate measurements when you do find an aneurysm, the proximal, the at, the distal, the length of it, and then again in transverse, proximal, at, and distal. Utilizing appropriate instrument settings, so we're not covering up a thrombus or we're not covering up a dissection, but we're going to use all of those gain settings, including our depth, our gain, our Doppler gain, our color Doppler. All of that is going to be essential here. And then finally, utilization of color and B mode together helps assess the size and function of anatomy, especially if you have an aneurysm that's filled with clot. That color within that aneurysm will really help represent that there is clot in the lumen. So a lot of different things to use, and hopefully you will find some of this a little bit helpful. And I hope you have a great day. And again, thank you so much for joining me.